Autosomal recessive polycystic kidney disease results from mutations in the PKHD1 gene, which encodes fibrocystin, a protein essential for normal renal tubular function. This genetic defect creates a cascade of cellular dysfunction that explains ARPKD's devastating clinical presentation. The pathophysiology centers on abnormal cilia function within renal tubules. Fibrocystin normally maintains proper ciliary structure and function, which regulates cellular signaling pathways controlling tubular development. When defective, these primary cilia cannot properly sense fluid flow or maintain normal cellular communication. This ciliary dysfunction leads to cystic dilatation, specifically of the collecting ducts. Unlike other cystic diseases, ARPKD affects the collecting system in a uniform pattern, creating the characteristic radiating cysts that give kidneys their enlarged, echogenic appearance on ultrasound. Progressive fibrosis accompanies cyst formation as normal renal parenchyma is replaced by fibrous tissue and cystic structures. This fibrotic process reduces functional nephron mass and impairs overall kidney function. Hepatic involvement occurs in 40% of cases through the same fibrocystin defect affecting bile duct development. Portal fibrosis develops, leading to portal hypertension with its associated complications. The clinical presentation directly reflects this pathophysiology. Massively enlarged kidneys cause abdominal distension and can compress the diaphragm, producing respiratory compromise. Oligohydramnios from decreased fetal urine production leads to pulmonary hypoplasia. Early renal failure produces electrolyte abnormalities requiring immediate management. When portal hypertension develops, patients risk gastrointestinal bleeding and splenomegaly. Understanding this pathophysiologic progression guides both immediate management and long-term planning for these complex patients. ARPKD management requires a pathophysiology-based approach targeting the specific organ dysfunction patterns characteristic of this disease. Respiratory support addresses the pulmonary hypoplasia resulting from oligohydramnios during fetal development. The underdeveloped lungs often require immediate mechanical ventilation at birth. Severe cases may need ECMO support when conventional ventilation fails to provide adequate gas exchange. The degree of pulmonary hypoplasia, not renal function, often determines initial survival. Renal replacement therapy becomes necessary as progressive nephron loss leads to uremia and electrolyte imbalances. Unlike other forms of chronic kidney disease, ARPKD often requires early dialysis initiation due to rapid functional decline. Peritoneal dialysis is typically preferred in neonates, though the enlarged kidneys may complicate catheter placement. Early transplantation planning is essential, often requiring bilateral nephrectomy to create space for the transplanted kidney. Hypertension management targets the dual pathophysiology of altered renin-angiotensin-aldosterone system activation combined with volume expansion from impaired renal function. ACE inhibitors provide optimal blood pressure control while potentially offering renal protection. Diuretics help manage volume overload but must be used carefully to avoid further compromising renal function. Hepatic complications require monitoring for portal hypertension development. The portal fibrosis creates increased resistance to portal blood flow, leading to varices formation and splenomegaly. Regular endoscopic surveillance becomes necessary to detect and treat esophageal varices before life-threatening bleeding occurs. This systematic, pathophysiology-guided approach optimizes outcomes by addressing each organ system's specific dysfunction pattern while preparing for long-term complications. Autosomal dominant polycystic kidney disease represents a distinctly different pathophysiologic process from ARPKD, despite both involving cystic kidney disease. ADPKD results from mutations in either PKD1 gene encoding polycystin-1 or PKD2 gene encoding polycystin-2. These proteins form a complex that regulates normal cilia function and cellular signaling pathways. The pathophysiology involves progressive cyst formation throughout life, rather than the uniform collecting duct dilatation seen in ARPKD. Defective polycystin proteins disrupt normal tubular epithelial cell function, leading to focal cyst development that gradually enlarges over decades. This explains why ADPKD typically presents later in life compared to ARPKD's neonatal presentation. In neonates, ADPKD rarely produces clinical symptoms. Unlike ARPKD, amniotic fluid volume remains normal because cyst formation hasn't yet significantly impaired overall renal function. Most affected neonates maintain normal kidney function and growth, making the diagnosis challenging without family history or genetic testing. When severe neonatal presentation does occur, it typically involves enlarged kidneys discovered on prenatal ultrasound or physical examination. However, these infants usually maintain adequate renal function, contrasting sharply with ARPKD's immediate renal failure. Critical differences from ARPKD include the dominant inheritance pattern requiring only one affected parent, later onset of symptoms, absence of liver involvement during childhood, and better preservation of renal function in early life. These distinctions reflect the different underlying cellular mechanisms and help guide appropriate management strategies and family counseling regarding prognosis and inheritance risks. ADPKD management in neonates and children focuses on surveillance and prevention rather than immediate intervention, reflecting the disease's typically benign early course. Neonatal and childhood management centers on regular monitoring to detect early complications before they become symptomatic. Renal ultrasound provides structural assessment, tracking cyst development and kidney growth over time. However, routine cyst counting in asymptomatic children provides little clinical value and may create unnecessary anxiety. Blood pressure surveillance is critical because hypertension can develop during childhood, even before significant cyst burden appears. The pathophysiology involves early activation of the renin-angiotensin system due to focal ischemia around developing cysts. Early detection and treatment of hypertension may slow disease progression. Urinalysis screening detects proteinuria and hematuria, which can occur from cyst rupture or developing glomerular dysfunction. These findings help guide timing of more intensive monitoring and potential intervention. Long-term complications require understanding of the progressive nature. Chronic kidney disease typically develops in adulthood as cyst burden increases and compresses normal parenchyma. Hypertension may manifest during childhood and requires aggressive management. Cerebral aneurysms, while concerning, don't warrant routine screening in asymptomatic children. Liver cysts develop commonly, but remain benign in most cases. Family counseling addresses the autosomal dominant inheritance pattern, meaning each pregnancy carries a 50% risk. Genetic counseling helps families understand implications, though pre-symptomatic testing in children remains controversial. The focus should be on optimizing long-term kidney health through lifestyle modifications and early intervention when complications develop. Multicystic dysplastic kidney disease results from a fundamental disruption in early nephrogenesis, specifically an arrest in metanephric development occurring before the 10th week of gestation. The pathophysiology involves failed interaction between the ureterobud and metanephric blastema, leading to complete absence of functional renal tissue. The defining pathophysiologic feature is ureteral atresia or absence, which prevents normal urine drainage. Without a patent collecting system, primitive nephric structures undergo cystic degeneration. These flua-filled cysts vary in size and lack communication with each other or with any collecting system. Importantly, no functioning nephrons develop. The affected kidney consists entirely of dysplastic tissue and cysts, with no capacity for glomerular filtration or tubular function. Clinical presentation typically involves prenatal ultrasound detection of a unilateral multicystic renal mass. Postnatally, physical examination may reveal a palpable flank mass, though affected infants remain asymptomatic due to compensatory function of the contralateral kidney. This compensatory hypertrophy begins in utero and enables the solitary functioning kidney to maintain normal renal function throughout life in most cases. The natural history of MCDK differs significantly from other cystic renal diseases. Progressive involution occurs in approximately 60% of cases, with complete radiographic disappearance possible by adolescence. This spontaneous regression reflects the non-functional nature of the dysplastic tissue and distinguishes MCDK from conditions such as polycystic kidney disease. Critical management considerations include thorough evaluation of the contralateral kidney, as associated abnormalities occur in 20 to 40% of cases. Vesicoureteral reflux represents the most common contralateral abnormality, followed by ureteropelvic junction obstruction. Regular surveillance with ultrasound and assessment of blood pressure remains essential, as patients with solitary kidneys face increased lifetime risk of hypertension and proteinuria. The prognosis for unilateral MCDK with a normal contralateral kidney remains excellent, with most patients maintaining normal renal function throughout life. However, long-term nephrology follow-up is warranted to monitor for potential complications, including hypertension, proteinuria, and the theoretical risk of malignant transformation in residual dysplastic tissue, though this remains exceptionally rare. Hydronephrosis is the pathophysiologic consequence of obstructed urinary flow, where rising intrapelvic pressure leads to dilation of the renal collecting system and eventual parenchymal injury. Understanding this cascade is essential for recognizing why early detection and timely intervention can preserve kidney function. The process begins with obstruction at any level of the urinary tract. As urine production continues against resistance, hydrostatic pressure in the renal pelvis increases. This elevated pressure transmits backward through the collecting system to the nephrons. Initially, the kidney compensates by decreasing GFR and enhancing tubular reabsorption. But sustained pressure leads to progressive structural distortion. Renal damage results from both mechanical and ischemic factors. Increased pressure compresses the renal vasculature, particularly the fragile peritubular capillaries, causing regional ischemia. Meanwhile, mechanical stretching of tubular epithelium triggers inflammation and fibrosis. Over time, this leads to tubular atrophy, interstitial scarring, and irreversible nephron loss. Functional tissue is gradually replaced by fibrosis, and the renal cortex thins. The Society for Fetal Urology grading system standardizes hydronephrosis severity using ultrasound. Grade 1 shows mild pelvic dilation with preserved architecture, reflecting minimal obstruction. Grade 2 involves moderate dilation extending into calyces, but still with normal cortical thickness. Grade 3 presents with severe dilation and identifiable cortical thinning, evidence of advancing damage. Grade 4, the most severe, shows massive dilation and a paper-thin cortex with loss of corticomedullary differentiation, signaling near total functional loss. Clinical correlation between grade and kidney function is essential for decision-making. Grades 1 and 2 often retain good function and may improve with time. In contrast, grades 3 and 4 are linked with significant nephron loss. Even after surgical correction, recovery of function is rare. Studies show that grade 4 kidneys often contribute less than 10% of total renal function on nuclear scans. This grading system informs both timing of treatment and prognostic counseling. Lower grades can often be managed conservatively with serial monitoring, as some resolve spontaneously. Higher grades demand prompt evaluation and often surgical correction to prevent further loss. Understanding this progressive pressure-related damage reinforces the importance of serial imaging. A kidney that progresses from grade 2 to grade 3 has crossed a critical threshold of irreversible injury. Ureteropelvic junction obstruction is the most common cause of congenital hydronephrosis, accounting for about 80% of cases. Its pathophysiology involves impaired urine flow from the renal pelvis into the proximal ureter, creating a functional bottleneck that leads to upstream dilation and potential kidney damage. Obstruction of the UPJ may be anatomic or functional. Intrinsic causes dominate and involve developmental abnormalities in the ureteral musculature at this transition point. Histology often shows disrupted smooth muscle architecture and excess collagen, impairing peristalsis. In some cases, spiral muscle fibers are replaced by longitudinal ones that cannot generate the propulsive force needed to move urine. This creates a functionally aperistaltic segment. Urine can't be transported effectively, even when the passage is open. Extrinsic compression accounts for about 20% of cases. Aberrant lower pole vessels crossing in front of the UPJ can create intermittent obstruction, especially as the renal pelvis fills. Fibrous bands or adhesions may also compress the junction. The concern is not only mechanical obstruction, but the secondary effects. Chronic compression leads to localized ischemia and fibrosis, converting a potentially reversible issue into a permanent one. Impaired urine flow causes predictable consequences. As urine accumulates, pressure in the renal pelvis rises and is transmitted backward through the collecting system. This initially causes calyceal blunting, then pelvic dilation, and eventually compresses the renal parenchyma. The kidney reduces GFR in response, but ongoing pressure leads to tubular atrophy and fibrosis. Without intervention, nephrons are lost through both mechanical injury and ischemia from vascular compromise. Clinical presentation mirrors this process. Prenatal ultrasound often detects isolated hydronephrosis, as the obstructed kidney still produces urine that cannot drain efficiently. Postnatally, a palpable flank mass may be the first sign. Older children may report intermittent flank pain during acute distension episodes, but neonates rarely show pain due to immature nociceptive pathways and the gradual nature of pressure buildup. This lack of pain poses a clinical challenge. Significant renal damage may occur without symptoms. Studies show that kidneys with severe UPJO can lose up to 50% of function before any signs appear. This underscores the importance of evaluating all prenatally detected hydronephrosis, regardless of symptom presence. Understanding the progressive nature of untreated UPJO is key to management. Early surgical intervention can preserve function, while delays in treating high-grade obstruction often lead to irreversible loss. The same pathophysiology explains why temporary drainage may allow partial recovery. Relieving pressure halts injury and may permit some regeneration in salvageable nephrons. Posterior urethral valves represent the most common cause of severe obstructive uropathy in male infants. The pathophysiology begins with abnormal embryologic development, creating obstructing membranous folds that act as a one-way valve during voiding. These tissue folds, located distal to the verumontanum, create a ball valve mechanism during micturition. As the bladder contracts, valves balloon out and occlude the urethral lumen, preventing normal urine flow. This chronic inlet obstruction initiates a devastating cascade of secondary changes throughout the urinary system. The bladder responds with compensatory detrusor hypertrophy, but this proves maladaptive over time. The thickened bladder wall develops trabeculations and diverticula. While sustained high pressures cause progressive detrusor dysfunction, the bladder transitions from a low-pressure storage reservoir to a thick-walled, poorly compliant organ, maintaining elevated pressures at rest. Elevated bladder pressure transmits to the upper urinary tract. Vesicoureteral reflux develops in 30 to 50% of cases as elevated intravesical pressures overcome normal anti-reflux mechanisms. High-pressure reflux and bilateral hydronephrosis lead to progressive renal parenchymal damage. Unlike other obstructions, renal injury in PUV begins in utero, resulting in renal dysplasia that cannot be reversed with early intervention. Severe cases manifest with oligohydramnios, as bilateral renal dysfunction limits fetal urine production. This creates a vicious cycle. Inadequate amniotic fluid prevents normal fetal lung expansion, leading to life-threatening pulmonary hypoplasia. Critically, bladder dysfunction persists after valve ablation due to irreversible structural and functional changes occurring during fetal development under obstructed conditions. The bladder wall undergoes fibrotic remodeling with altered collagen deposition and smooth muscle architecture. Chronic obstruction disrupts neural pathway development, resulting in neurogenic bladder patterns. This persistent dysfunction, termed valve bladder syndrome, manifests as reduced compliance, detrusor overactivity, and incomplete emptying. Up to 80% of patients have abnormal urodynamic parameters years after valve ablation, driving progressive upper tract deterioration throughout childhood. Understanding this pathophysiology explains why PUV management extends beyond valve ablation. Patients require lifelong urologic surveillance, with bladder management strategies to minimize renal injury. The irreversible nature of renal dysplasia and bladder dysfunction explains why PUV remains a leading cause of pediatric end-stage renal disease. The clinical presentation of posterior urethral valves directly reflects chronic urinary obstruction and its cascading effects on the genitourinary system. Each clinical finding traces back to specific pathophysiologic mechanisms. Poor urinary stream represents the most direct manifestation of valve obstruction. During voiding, membranous valve leaflets balloon out and obstruct flow, resulting in weak, dribbling streams rather than normal, forceful arcs. Parents report prolonged voiding times or incomplete emptying. This finding is most apparent in older infants, though subtle in neonates with severe bilateral reflux who decompress through upper tracts. A palpable bladder indicates chronic urinary retention from incomplete emptying. The pathophysiology involves both mechanical obstruction and progressive detrusor dysfunction. The chronically distended hypertrophied bladder may extend above the pubic symphysis, sometimes reaching the umbilicus. This differentiates PUV from other causes of bilateral hydronephrosis, where bladder distension is absent. Respiratory distress at birth signals the most severe PUV spectrum. The sequence begins with severe bilateral obstruction causing marked oligohydramnios. Without adequate amniotic fluid for fetal lung expansion, pulmonary hypoplasia develops. Respiratory compromise correlates with oligohydramnios timing and severity. Onset before 20 weeks carries gravest prognosis. Failure to thrive reflects metabolic consequences of chronic renal insufficiency. Even after successful valve ablation, many infants struggle with poor growth due to renal tubular dysfunction, chronic metabolic acidosis, and poor feeding from uremia. Polyuria from concentrating defects leads to chronic dehydration, further compromising growth. Long-term outcomes demonstrate irreversible early renal and bladder damage. Approximately 30% develop chronic kidney disease, requiring dialysis or transplantation by adolescents. This reflects both congenital renal dysplasia and ongoing injury from persistent bladder dysfunction. Valve bladder concept is crucial. Optimal surgical management cannot restore normal bladder function once developmental changes occur. Persistent bladder dysfunction manifests as urinary incontinence, recurrent infections, and progressive upper tract deterioration. Over 50% continue significant voiding dysfunction into adulthood, requiring medical management. Risk stratification helps predict outcomes. Serum creatinine greater than 1.0 mg/dL at 1 year, bilateral vesicoureteral reflux, and early bladder dysfunction portend worse long-term renal outcomes, guiding surveillance intensity and aggressive bladder management strategies. Renal vein thrombosis represents a serious vascular emergency in neonates, with pathophysiology centered on venous outflow obstruction leading to progressive renal congestion, hemorrhage, and potential organ loss. The pathophysiology begins with thrombus formation within the renal vein, typically at sites of endothelial injury or blood flow stasis. Once established, the clot obstructs venous drainage while arterial inflow continues unimpeded. This creates progressive increase in intrarenal venous pressure. As venous pressure approaches arterial pressure, renal perfusion decreases dramatically, despite maintained systemic blood pressure. The kidney responds to venous congestion with progressive swelling as blood accumulates. Increased venous pressure transmits to glomerular capillaries, causing hemorrhage into Bowman space and renal tubules, explaining the characteristic gross hematuria. As congestion worsens, the renal capsule becomes tense, further compromising perfusion through mechanical compression. Without intervention, progressive ischemia leads to acute tubular necrosis and potential cortical necrosis. Multiple risk factors create the prothrombotic state necessary for RVT development. Perinatal asphyxia causes widespread endothelial damage through hypoxic injury and reperfusion-related oxidative stress. The damaged endothelium exposes subendothelial collagen, activating the coagulation cascade. Polycythemia increases blood viscosity and promotes sluggish flow within the renal venous system. Dehydration compounds risks through hemoconcentration, further increasing blood viscosity while reducing flow rates. Maternal diabetes contributes through multiple mechanisms. Infants often have polycythemia, increased platelet aggregability, and elevated prothrombotic factors. The left-sided predominance relates to anatomic factors. The left renal vein is approximately 3 times longer than the right, traversing between the aorta and superior mesenteric artery before joining the inferior vena cava. This longer course creates more opportunity for compression, turbulent flow, and stasis. The temporal progression explains variable outcomes. Early thrombosis may be reversible if venous drainage is restored before irreversible ischemic injury occurs. However, complete venous occlusion lasting more than 4 to 6 hours typically results in hemorrhagic infarction. The infarcted tissue undergoes necrosis and eventual fibrotic replacement, leaving a small, scarred kidney with minimal function. This pathophysiology has critical management implications. Early anticoagulation may prevent thrombus extension and preserve collateral venous drainage. However, Once hemorrhagic infarction occurs, anticoagulation carries significant bleeding risk with limited benefit. This narrow therapeutic window emphasizes the importance of high clinical suspicion and rapid diagnosis in at-risk neonates. The clinical presentation of renal vein thrombosis exemplifies how pathophysiologic mechanisms directly manifest as observable clinical findings. Each component of the classic triad can be traced to specific consequences of venous outflow obstruction and resulting renal injury. The palpable flank mass represents immediate consequence of venous congestion. When venous outflow becomes obstructed, arterial blood continues entering the kidney while drainage ceases. This causes progressive organ swelling as blood accumulates within renal parenchyma. The kidney enlarges rapidly, sometimes doubling in size within hours. The tense renal capsule creates a firm, palatable mass extending from the costovertebral angle toward the anterior abdomen. Hematuria constitutes the most visible sign of ongoing renal injury. The pathophysiologic basis involves venous hypertension, transmitted retrograde to glomerular capillaries. As venous pressure approaches arterial pressure, delicate glomerular capillary walls rupture, releasing blood into Bowman's space. This blood traverses the entire nephron, appearing as gross hematuria. Massive hematuria suggests extensive glomerular hemorrhage and poorer prognosis for functional recovery. Thrombocytopenia completes the classic triad and provides insight into thrombus formation dynamics. Platelets become consumed within the growing clot, leading to measurable decreases in circulating platelet counts. This consumption coagulopathy differs from disseminated intravascular coagulation, as other coagulation parameters remain relatively normal. Serial platelet counts provide valuable information about disease progression. Hypertension develops through renin-angiotensin-aldosterone system activation secondary to renal ischemia. The congested kidney interprets decreased perfusion as systemic hypotension, triggering massive renin release. This can produce severe hypertension within hours, typically proving difficult to control with standard agents. Oliguria reflects functional renal impairment degree. In unilateral RVT, urine output may remain normal if the contralateral kidney functions well. However, bilateral involvement produces profound oliguria through decreased glomerular filtration and tubular obstruction from hemorrhagic debris. Anemia develops through multiple mechanisms, including blood loss into renal parenchyma, decreased erythropoietin production, and microangiopathic hemolysis as red blood cells traverse partially occluded vessels. Extension to the inferior vena cava represents particularly ominous development. When thrombus propagates beyond the renal vein, it can occlude venous return from the lower body, producing bilateral leg edema and cyanosis. This finding mandates immediate imaging and consideration of thrombolytic therapy. The management of renal vein thrombosis requires careful consideration of underlying pathophysiology and temporal evolution of thrombotic injury. Treatment decisions must balance potential benefits of restoring venous flow against intervention risks, particularly in the context of evolving hemorrhagic changes within the affected kidney. Anticoagulation therapy represents the cornerstone of RVT management when implemented early. The rationale centers on preventing thrombus extension rather than dissolving existing clot. Unfractionated heparin or low molecular weight heparin prevents activation of additional coagulation factors, limiting propagation into collateral venous channels. Preserving these collateral vessels proves critical, as they may provide alternative drainage pathways maintaining some renal perfusion. The therapeutic window remains narrow. Anticoagulation initiated after hemorrhagic infarction carries substantial bleeding risk without meaningful benefit. Thrombolytic therapy with tissue plasminogen activator represents a more aggressive approach reserved for specific scenarios. The mechanism involves direct clot dissolution through plasminogen activation to plasmin, which degrades fibrin strands. This offers theoretical advantage of restoring venous patency and salvaging threatened but viable renal tissue. However, Risk of catastrophic hemorrhage, particularly intracranial bleeding in neonates, limits use to bilateral RVT or thrombosis in a solitary kidney, where the alternative is certain renal failure. Supportive care addresses systemic consequences while the kidney's fate evolves. Hypertension management often requires multiple agents, as renin release from a She's kidney creates resistant hypertension. Careful fluid balance prevents further hemoconcentration while avoiding volume overload. Correction of underlying prothrombotic states reduces risk of contralateral involvement. The relationship between initial injury extent and long-term outcomes follows predictable patterns. Partial thrombosis with maintained collateral flow may result in complete functional recovery, particularly with early anticoagulation. Complete venous occlusion typically leads to irreversible changes within hours, progressing from congestion to hemorrhagic infarction to fibrotic replacement, leaving a small, non-functioning kidney. The mortality rate of 3% primarily reflects deaths from underlying conditions rather than direct RVT complications. Among survivors, long-term morbidity relates to renal functional loss and persistent hypertension. Follow-up protocols must address immediate complications and long-term sequelae. Serial imaging documents evolution from acute swelling to chronic atrophy. Nuclear medicine scans quantify differential renal function. Blood pressure monitoring remains essential throughout childhood, as hypertension may develop years after the acute event. Renal artery thrombosis represents a distinct vascular catastrophe, with pathophysiology fundamentally different from venous thrombosis. While venous occlusion produces congestion and hemorrhage, arterial occlusion causes immediate cessation of blood flow, resulting in rapid ischemic injury. The pathophysiology follows principles of end-organ ischemia. When the renal artery becomes occluded, oxygen delivery ceases abruptly. Unlike venous thrombosis, where some arterial flow continues initially, arterial occlusion produces immediate cellular hypoxia. Within minutes, ATP depletion begins, particularly in metabolically active proximal tubular cells. The sodium-potassium pump fails, leading to cellular swelling and membrane disruption. This ischemic cascade progresses more rapidly than venous thrombosis because no residual perfusion exists. The kidney responds to complete ischemia with massive renin release from the juxtaglomerular apparatus. This represents a maladaptive response. The kidney interprets absent perfusion as systemic hypotension and attempts to restore blood flow through systemic vasoconstriction. The resulting severe hypertension often provides the first clinical clue, as the ischemic kidney may produce no urine and cause no visible hematuria, unlike venous thrombosis. The association with umbilical artery catheters deserves attention given the frequency of this iatrogenic complication. Catheter tips positioned at or above renal artery level create multiple thrombosis mechanisms. Direct endothelial trauma from the catheter tip initiates local thrombus formation. Turbulent flow around the catheter disrupts normal laminar patterns, creating stasis areas. Microthrombi form on catheter surfaces and embolize to renal arteries. Risk increases with catheter duration, malposition, and hypertonic solutions. An important distinction exists between complete and partial arterial occlusion. Complete occlusion leads to cortical necrosis within 60 to 90 minutes with irreversible nephron loss. However, partial occlusion or segmental emboli may preserve some perfusion through collateral vessels. The renal artery's segmental branching means emboli often lodge at bifurcations, causing wedge-shaped infarcts rather than global kidney necrosis. Clinical presentation often proves surprisingly subtle initially. Unlike the dramatic triad of renal vein thrombosis, arterial occlusion may produce no immediate physical findings. The affected kidney neither swells nor bleeds. Urine output may remain normal if the contralateral kidney functions well. This silent presentation delays diagnosis until severe hypertension develops. Collateral circulation development influences outcomes significantly. While the kidney normally relies on end arterial supply with limited collaterals, chronic partial occlusion can stimulate capsular and periureteral vessel enlargement, maintaining viability of renal capsule and collecting system while cortex infarcts. Neonatal hypertension represents a complex disorder with multiple etiologies operating through distinct pathophysiologic mechanisms. The definition reflects unique neonatal physiology. Blood pressure exceeding the 95th percentile for postmenstrual age acknowledges that normal values change dramatically during transition from fetal to postnatal circulation. Renal artery stenosis prids systemic hypertension through hormonal mechanisms. The stenotic vessel reduces renal perfusion pressure, which the juxtaglomerular apparatus interprets as systemic hypotension. This triggers excessive renin release, activating angiotensin II production and aldosterone secretion. The resulting vasoconstriction and sodium retention produce severe resistant hypertension. Coarctation of the aorta produces hypertension through mechanical means. The anatomic narrowing creates fixed obstruction, generating a pressure gradient. Vessels proximal to coarctation experience elevated pressure as the left ventricle works against increased afterload. Upper extremity blood pressure may be severely elevated, while lower extremity pressures remain normal. Renal parenchymal disease causes hypertension through combined volume overload and inappropriate real AAS activation. Damaged nephrons cannot adequately excrete sodium and water, leading to volume expansion. Simultaneously, scarred or ischemic renal tissue continues producing renin despite volume overload. Medication-induced hypertension operates through various mechanisms. Corticosteroids enhance sodium retention and increase vascular sensitivity to catecholamines. Sympathomimetic agents directly stimulate alpha and beta receptors, increasing cardiac output and systemic vascular resistance. Hyperintensive complications reflect neonatal target organ vulnerability. Retinal hemorrhages occur when fragile vessels rupture under sudden pressure elevation. The immature blood-retinal barrier makes vessels particularly susceptible to barotrauma. Acute heart failure develops when hypertension rapidly increases afterload beyond the neonatal myocardium's limited reserve. The immature left ventricle cannot generate sufficient force against elevated systemic resistance, leading to pulmonary congestion. Hypertensive seizures result from cerebral edema and hemorrhage secondary to failed autoregulation. Acute severe hypertension overwhelms autoregulatory mechanisms, causing hyperperfusion, blood-brain barrier disruption, and vasogenic edema. Hypertension management in neonates requires precise understanding of cardiovascular physiology and the delicate balance between adequate organ perfusion and pressure-related injury. The therapeutic approach differs between acute hypertensive crisis and chronic hypertension, with each requiring specific physiologic targets. In acute, severe hypertension, the primary goal involves controlled blood pressure reduction to prevent target organ damage while maintaining adequate perfusion. The critical principle is avoiding precipitous drops that compromise cerebral, coronary, and renal blood flow. Neonatal organs operate within narrow autoregulatory ranges, and sudden pressure changes can cause ischemic injury. The target of no more than 25% reduction in the first hour reflects this reality. Autoregulatory mechanisms require time to reset. More aggressive reduction risks watershed incarcs and acute tubular necrosis. Esmolol represents an ideal agent for acute management due to its ultra-short half-life and beta-selective blockade. The drug reduces cardiac output through negative chronotropic and inotropic effects while avoiding peripheral vasodilation that could cause precipitous drops. Its rapid onset and offset allow minute-to-minute titration. Nicardipine offers complementary mechanism through selective calcium channel blockade in vascular smooth muscle. By reducing systemic vascular resistance without significant cardiac depression, it addresses hypertension driven by elevated afterload. The drug's preferential effect on cerebral vessels helps prevent hypertensive encephalopathy while maintaining perfusion. Chronic hypertension management targets underlying pathophysiologic mechanisms rather than just numerical goals. ACE inhibitors directly interrupt the renin-angiotensin-aldosterone cascade, proving particularly effective for renal causes. By blocking angiotensin II formation, these agents reduce both vasoconstriction and aldosterone-mediated sodium retention. However, use requires careful monitoring of renal function and potassium levels. Calcium channel blockers serve as excellent alternatives, particularly when RAS blockade is contraindicated. Their reduction of vascular smooth muscle tone addresses hypertension regardless of etiology. Longer-acting formulations provide steady pressure control without peaks and troughs. Diuretics address volume-mediated hypertension by promoting sodium and water excretion. In neonates with renal parenchymal disease, volume reduction may be the primary therapeutic need. However, use requires careful attention to electrolyte balance. Monitoring extends beyond blood pressure measurement. Serial renal function assessment ensures adequate organ perfusion. Growth velocity serves as a sensitive indicator of cardiovascular health. Regular fundoscopic examinations detect early retinal changes. Echocardiographic monitoring assesses left ventricular hypertrophy regression.